Good afternoon. My name is Sean Kielty, and this is a SRU Rural Health Care Services Outreach Program grant proposal for Health 627, entitled Improving Access to Healthy Food and Nutrition, Education for Low-Income Households in Bucks County, Pennsylvania. Improving access to healthy food, an introduction. The organization is Bucks County Community Health Collaborative. To give a little bit of background, although Bucks County is often viewed as an affluent and healthy community, significant health disparities exist among low-income and ALICE households. Many residents struggle to consistently access nutritious foods and essential resources despite being employed. Now, the term ALICE is broken down into later on. And the key issue here is food insecurity continues to impact thousands of families throughout Bucks County and contributes to long-term public health challenges within the county. The problem statement is essentially food insecurity in Bucks County impacts approximately 64,000 residents. That is almost 10% of the county population being affected. We have almost 650,000 people county-wide here in Bucks County. That means approximately 1 in 9 children face food insecurity, and 20% of households are classified as ALICE households, 27%. So roughly a quarter of the 650,000 or 640,000 for easy math, which would result in approximately 160,000 people, although only about a third of them, between half and a third, would be infected by food insecurity. These 27% would still qualify as ALICE households, and that's asset limited, income constrained, but employed. So essentially living paycheck to paycheck, not many assets to rely upon, and the income, very little disposable income, if any, it's constrained. These households often earn too much to qualify for assistance programs, but cannot meet basic living expenses, right? So they're not, they don't qualify for aid, either the state or federal level, but they're still in desperate need of it. Health consequences for being an ALICE household or being food insecure. Food insecurity is associated with increased risk for obesity. I know it's counterintuitive, but obesity results from having really volumes of food that are not terribly nutritious but are high in calories. So really the cheapest, most processed foods. Type 2 diabetes also, as a result of those processed and refined flour and sugar foods, very high in sugars and carbohydrates that are refined, which are essentially complex sort of sugars, starches that are complex sort of sugars. If you've ever done the experiment in biology class from high school, as I have, take just a plain cracker, saltine with no salt, and chew it for about a minute to 2 minutes, it gets very, very sweet. The enzymes in your mouth start to break down those simple starches into simpler sugars, and along with the mechanical particulation and then solution of those starches that break down into the sugars, that saltine becomes very, very sweet. It leads to hypertension as well, food insecurity. The processed foods have a lot of salt in them, and they also have other sources of sodium, like monosodium glutamate and other preservatives that are not good for you and can also lead to hypertension. Cardiovascular disease, so heart disease. The cardiovascular system, these processed foods are usually very high in saturated fats. A certain amount of fat is, of course, essential for life, but they should be monounsaturated fats or lower amounts of saturated fat in general. And they also lead to depression and anxiety. There's a close correlation between not just the food insecurity itself, but the food that you are able to consume when you're food insecure, being heavily processed, very high in carbohydrates, high in unhealthful fats, and those can be closely associated with poor production of everything from neurotransmitters to serotonin levels to dopamine production across the board systemically. This disproportionately impacts children, as everything that has to do with poverty does, or an unemployed form of poverty. Children experiencing food insecurity may face developmental delays as far as school is concerned, poor academic performance, behavioral challenges due to once again, the highly processed, high carbohydrate, high unhealthy fat food consumption, and long-term health consequences that we went over previously. Barriers to healthy food access and major community challenges, as well as economic barriers, are among the many factors to place in the equation of any kind of disproportionate health risk as far as food insecure homes. We have economic barriers, especially now, high food prices, rising housing costs, including electricity, limited financial resources, and very little marginal resources or disposable resources to pay for healthier food. The more intrinsically healthy foods, such as fruits and vegetables and unprocessed protein sources, as well as healthier carbohydrates that are coming from whole grain rather than just refined flour and sugar, are more difficult to purchase because of their expense. The access barriers include transportation limitations. If you don't have access to a vehicle and you're not in an area that has public transportation, or reliable public transportation, trying to find more than one very small, very limited grocer would be difficult. There's limited grocery stores in underserved areas. For instance, if you were in, say, Dublin, Pennsylvania, kind of at the center of Bucks County, and you just had the Weiss or the Wawa there that you could get to if you didn't have a car to go to Doylestown or up to Quakertown for a better selection of food, you would probably be experiencing some kind of food desertification. Lack of affordable fresh produce is another factor. The convenience stores where a lot of people would be able to go to are not necessarily healthy if they're the single source being relied upon. Program limitations, restricted SNAP eligibility. Again, ALICE households are not necessarily eligible for SNAP. They may essentially price themselves out of their eligibility for that program. Gaps in long-term nutrition support also exist as a result, just of kind of being in the donut hole between being so impoverished that you'd be eligible for state and federal aid, and making too much money, or making enough money to be on the eligibility, but not enough to really survive without some kind of assistance. So we'd also go into the existing community resources such as food banks, current services in Bucks County. There are several food banks. I wouldn't say plenty, and they're not accessible when people don't have reliable sources of transportation to get to them. They're not as decentralized as they should be. They're kind of clustered around different urban areas, such as like Levittown or Warrington or Doylestown, or even near New Hope. There's community pantries. There's also faith-based organizations such as churches, synagogues, and mosques, and there are social services. There are programs within the county that can help assist on some level, but they're just not as reliable or as broad as the SNAP program or other programs. Current gap fillers include most services focus on emergency food assistance rather than long-term nutrition improvement. So once again, it's unreliable, episodic kind of food assistance. And then also none of them kind of so it's an emergent sort of support rather than being long-term. So chronic disease prevention is also not factored into these emergent food assistance programs, nor are sustainable healthy eating behaviors encouraged. They're just trying to get the closest resource to the nearest need, so to speak, during the emergency. There are proposed initiatives, healthy food access and nutrition education initiatives. The one that's in the grant here proposed is a 3-year rural health initiative. The initiative combines healthy food distribution, nutrition education workshops, which really teach people how to make the most of the food they have, as far as creating dishes or meal planning or budgeting for food, as well as mobile food distribution. An excellent example of that would be Meals on Wheels, which is, although it's a national program, it's managed at a more local level. There's community outreach, transportation assistance, so that people can go to the store regularly, and a more diverse grocery store in order to ensure that they have not only healthy food or more healthful food, they also have lower prices compared to convenience stores, so the purchasing power is greater. There's also multilingual support for those who are not native English speakers and have difficulty communicating effectively when it comes to purchasing healthy food. Primary goal of this proposal, of course, is the improve access to healthy food while promoting nutrition education and chronic disease prevention. That's really a win-win-win. When you're promoting nutrition education, you're statistically more likely to avert any kind of chronic illness associated with malnutrition, or in the case of, as well as in the case of improper nutrition or injurious consumption that leads to diabetes and obesity. We also get into healthy food distributions with this proposed grant program, expanding access to nutritious foods, community partnerships. The program would collaborate with local farms, grocery stores, food banks, and schools, as well as healthcare providers and faith-based organizations, kind of all of we would call them VOAD in an emergency situation, the volunteer organizations that are active during disaster, but more of a planned and sustained assistance rather than episodic based on emergencies. The annual objective would be to distribute healthy food packages and fresh produce to at least 1,500 households annually, and that would be on a weekly or monthly basis. Additional strategy would be to develop mobile food distribution sites to serve transportation limited populations. So anyone without ready transportation or private transportation would be able to still sign up for these programs and get these food distribution opportunities. Nutrition education program would be critical, as well as monthly nutrition education workshops that were discussed before. The workshop topics would be healthy meal preparation, grocery budgeting, food safety as far as ensuring proper refrigeration and storage, the reading and understanding of nutrition labels, and chronic disease prevention, as well as culturally appropriate cooking demonstrations if you are raised in the tradition of a certain type of ethnic cuisine, and the transition to a more established traditional American menu is difficult for whatever reason, just because of lack of familiarity. The cooking demonstrations can be very helpful. Accessibility in person sessions, as far as accessing the food, virtual learning opportunities for those who have access to a cell phone, which seems like virtually everyone these days, as well as multilingual educational materials for those for whom English is not primary language. The annual goal would be to serve 500 participants each year as a minimum, but growing, of course, to that goal of 1,500 households on a weekly or bi-weekly or monthly basis. All right, project goals, program goals. Project is the project itself. The program is the sustained project, essentially. Goal 1 is increasing the access of healthy foods among low-income households, specifically ALICE households, who are not otherwise covered by some kind of federal, state, or local program. Goal 2 is to improve nutrition knowledge and healthy eating behaviors among those who are impacted as a result of being in this donut hole of income, vice, eligibility for these programs. And then the goal 3 would be to reduce risk factors associated with nutrition-related chronic diseases such as obesity, type 2 diabetes, and the like. Okay, measurable objectives for project objectives. By the end of the program initiative, we'll have served at least 1,500 households annually, conduct monthly nutrition workshops, reach at least 500 participants each year. So it bases it over the 3-year period, 500 people per year, and then at the end, 1,500 annually is the minimum goal. Improve nutrition knowledge scores by 25%. However, we were going to do these assessments. I believe it would be more of a practical assessment rather than a written test, because generally people learn best by doing, and if they're participating in these workshops or these cooking demonstrations, they would get a lot more out of it than just simply sitting down and taking a test that doesn't necessarily apply that knowledge to reality. Increase food and vegetable consumption by 20%. So if it's only 10% of their diet now, boosting it up to 12%, which I think is a significant increase. 20% increase on what they were already consuming. Improve confidence in healthy meal preparation and budgeting. I think that's critical, especially for people who are go to convenience foods too often, as a result suffering from inappropriate nutrition when it comes to far too much carbohydrates and far too much unhealthy fats. The best way to evaluate the program, you have a program evaluation consisting of evaluation plans and then the process evaluation. The program will track number of households served, food distribution totals, workshop attendance, community partnerships that are established as a result of the program. The outcome evaluation, which is not the process evaluation, right? One has to do with the actual doing or establishing of this project to program. The outcome is what is actually produced, so the program will assess changes in nutritional knowledge, dietary behavior improvements, as well as food security status and participant satisfaction. And then, of course, we're going to be doing the customer survey or data collection methodologies. It would be surveys for the individuals who are participating in the program, focus groups to see what the actual upshots are of the program performance, attendance records for the workshop and other aspects of the program that require participation, and then stakeholder interviews as far as those who are who are both participants, and then those who are participants, as well as those who are participating in the form of donations or program support. All right, so the logic model for the program logic model essentially is inputs of federal funding, community partnerships, nutrition educators, volunteers, food donations. These are would be pardon the pun, but the bread and butter of the inputs for this program. The activities would be the food distribution itself, nutrition educational programs, mobile outreach events, and program evaluations that we just talked about. The short-term outcomes would be improved nutritional knowledge among the participants, increased food access, and better budgeting of skills as far as ensuring that you're getting the biggest healthful consumption bang for your buck as far as those who are participating. And then long-term outcomes, reduced food insecurity, lower chronic disease, and of course improved community health outcomes. With sustainability plan as well, long-term sustainability. Sustainability strategies would consist of continued partnership with community organizations, as well as volunteer recruitment and training. We'd also have additional grant funding opportunities as a result of this proposed grant, and ultimately we would also have community fundraising initiatives and integration into existing public health systems, so in cooperation with whether it's hospitals or urgent cares or other